Okay, so let's talk about testings. In the testing, basically you're trying to find the best modalities possible to help you arrive at your diagnosis. In testing, you have different tests to use for cardiovascular related complaints. EKG is most frequently used and it's very easy. It can be done in the ER. Cardio markers, which takes a couple of hours to come back. You have to do a subset of these. And chest x-ray, which is also very easy to do, can also be done in the ER. In EKG, essentially the goal is to follow a specific rhythm. This is not a course on learning how to read EKG. This is something that even the residents, third and fourth year, are still mastering or are still learning. It's hard. But the way to follow this is to go through rate, rhythm, axis, P wave, QRS, ST segment, T wave, and U wave. Just follow this rhythm and just stick with it from now till your wards, until you graduate, or whatever the case may be. So let's start with the rate. The rate is either fast or slow. It can be normal, and in this case, you're not considering any tachycardia type pathology or bradycardia type pathology. But a fast rate will be anything above 90. A slow rate will be anything less than 60. So I urge you to always highlight your heart rate, highlight your vitals, because the vitals, in the end of reading this thick paragraph, your vital may bring you back to what you think the central theme of this question is and what they're trying to ask you. So bradycardia is a person who has a heart rate less than 60. In these individuals, it's usually due to the node blockage. You have the SA node, you have the AV node, you have the bundle of His, you have the Purkinje fibers, all of that. Something is blocking the electrical transport through these pathways. All right, and the most common ones are the AV node blockade. In the AV node blockade, you have the first degree heart block, second degree heart block, which has two types, morbus type 1 and morbus type 2. And then you have the third degree heart block. Again, there's a specific section for these, and we will talk about it. On the other hand, tachycardia is when the person's heart rate is more than 90 beats per minute. Again, highlight your vitals. In these individuals, it can be both physiologic or pathological. In physiologic, usually a person who's exercising or doing something that you expect that their heart rate is going to increase, that's where you see this. In the pathological tachycardia, it has to do with atrial problems, maybe multi-atrial tachycardia, PSVT, all these different pathology that may lead to the heart rate pumping faster. Ischemia, coronary artery disease, prolonged QT syndrome, myopathy, and drugs are things that may affect the ventricle and cause ventricular type tachycardia. Then you have re-entry circle, which has to do with the AVRT and the AVNRT. This has to do with the Wolff-Parkinson-White syndrome and a whole bunch of other things that may not be specifically high yield here. Wolff-Parkinson-White syndrome is high yield. Again, what am I saying here? I'm saying that you have things that may lead to increasing the heart rate more than 90 beats per minute. Then you talk about the rhythm. The rhythm is a specific pattern of how the P wave comes and the QRS comes and then the T wave comes. There's a rhythm in that, and you have to have it repeatedly. In an individual where there's a P wave before, every QRS complex is considered to be in a sinus rhythm. In cases where you don't see a P wave at all, then you know this is a pathological rhythm going on here. So pathological rhythm will involve things like bradyarrhythmia or tachyarrhythmia. Again, supraventricular, which has to do with the atrium section, or ventricular, which has to do with the ventricle section. Just understand that as you read your EKG, this rhythm does not look normal to you. You have to think about some form of a arrhythmia. We'll continue, we say axis. The axis, you want to know if this is a right axis deviation or a left axis. People get so bogged down into the definition of right axis deviation, the M versus the W, the William, this and that. We will talk about it in just some tiny detail, but again, that's going to get you lost from seeing the big picture of what's happening here. So in the axis, you can see normal axis where everything is pointing in the right direction. You can see left axis deviation versus right axis deviation. So again, you have right axis, you have left axis deviation. In left axis deviation, you are thinking about the tricuspid atresia or hyperplastic left heart syndrome. Let's talk about P wave. In the P wave, again, you want to know if there's P wave or an absence of a P wave. Whenever there's an absence of a P wave, you in all the sections, then you know you're dealing specifically with some kind of atrial problems here. But if we talk about the AV blockade, and you have first, second, and third degree block, that's also will affect the P wave in some way, shape, or form. Then you have the pre-AV blockade versus the post-AV blockade. This is where your left bundle branch block comes in and your right bundle branch block comes in. In a post-AV blockade, this is where you have this mnemonic William Morrow. So the W and the M, basically left bundle branch block versus right bundle branch block. Let's continue and talk about the QRS complex. This is exactly telling you the depolarization of the ventricles. It also has a buried of the repolarization of the atrium in here. So when the QRS complex, you know this person has an arrhythmia, and the QRS complex seems narrow, you can think about what to treat with that person. You give adenosine. In cases where it's wide, you give the holy grail of antiarrhythmics, which is amiodarone. There are cases where you may see a Q wave, which indicates an OMI, and there's a case where you may see a prolongation of the QT interval, which may indicate to start the point. There are a lot of antiarrhythmics, especially in class 1 antiarrhythmics, are also prone to providing prolongation of the QT interval, which can cause to start the point. Then you talk about the ST segment. Essentially, this is where you deal with the elevation and depression. Depression, which means ischemia of the heart. Wolff Parkinson White can also present with ST depression. And elevation, this is where you deal with the acute coronary syndrome, which we say is unstable angina, non-STEMI and STEMI versus the variant angina as well. Then you talk about the T wave. T wave specifically deals with the electrolytes balances. T wave eversion versus elevation. In electrolytes imbalances where you have hypo or hyperkalemia, that's when you deal specifically with the T wave. Hyper, long or tall T wave. Hypo, short or flattened T wave. Simple. Then you continue to the U wave. The U wave essentially has to do with the atrium. It can be present or absent and has to do with the atrial repolarization. As you recall, that the QRS complex depolarization process may swallow the atrial repolarization process, so you may or may not see that. Then you continue in terms of your testing, you do cardiac biomarkers. One of the most important cardiac biomarkers to use is troponin. Troponin usually takes about 7 days to peak, and it fades in the next 7 days or so. You have troponin I, which is very important. You have all the different variants of troponin. You can also do the CKMB, which essentially is more important to help you with understanding reinfarction. You can also do myoglobin, which is given because what's being damaged is also heart muscles. Then you can do a chest X-ray, which is very easy to do and is faster, and it's done usually in the ER. It really can help you distinguish between pulmonary embolism versus pneumothorax. You may see widening of the mediastinum on the chest X-ray. You may also see air in the mediastinum as well in the chest X-ray. It appears as this cluster or pocket of dark section within the chest X-ray. Why did I take time to go through all of this? I hope you don't spend so much time on it, because most of these things are supportive information that helps you make sense of the clinical vignette. So think about this as you're reading the clinical vignette. Keep these things in the back of your mind. This is dealing with the clinical presentation.